We welcome Dr. Niranjana of ICH to present her case.
Hello.
Good afternoon, one and all gathered here. I am Dr. Niranjana from Institute of Child Health. I am here to present the diagnosis and management of congenital heart disease. This is a 2-year-old, 9 months male child who born to a third-degree consanguineous marriage, who is a known case of some congenital heart disease, now admitted for surgical intervention. The child also has a failure to gain adequate weight since birth and frequent recurrent history of respiratory tract infections. History of presenting illness. Child was asymptomatic until 45 days of life, after which developed cough and cold associated with breathlessness. There was also a history of forehead sweating and suppressed suck cycle. For the above complaints, the child was taken to a private hospital and was diagnosed to have some cardiac issues and was referred to higher center for further evaluation. There the child was diagnosed to have heart disease and started on medications since 2 months of life. Thereafter the child is on regular follow-up once in 3 months in our cardiology OP. There is a history of recurrent episodes of respiratory tract infections in the form of fever, cough and cold, at least thrice a year, requiring most of them requiring IV antibiotics and hospitalization. There was also history of increased precordial activity noted by the mother since 1 year of age. Now the child complains of breathlessness on exertion. According to New York Heart Association, comes under grade 2 non-progressive breathlessness, initially present with no diurnal variation, no history of pedal edema or decreased urine output, no history of orthopnea or paroxysmal nocturnal dyspnea. The child complains of mother complains of not gaining adequate weight since birth. There is no history of bluish discoloration of lips, palms and soles, no history of any squatting episodes, and no history of altered level of consciousness or any seizure episode, focal deficits, no history of hoarseness of voice or hemoptysis. There is no history suggestive of any persistent fever, hematuria or painful swelling over fingertips. Past history, as I already said, the child is a known case of congenital heart disease on oral medications. There is his frequent hospitalization for lower respiratory tract infection. Antenatal, uneventful, there is no history suggestive of any fever with rash, arthralgia or post-auricular swelling, no history of any drug intake or gestational diabetes mellitus or pregnancy-induced hypertension. Natal history, it's a term baby, normal vaginal delivery, 2.3 kg, cried immediately after birth, and postnatal history uneventful. No evidence of cyanosis or breathlessness, NICU admission in the newborn period, developmentally normal child. Diet history, child takes 900 kilocalories as expected against 1200 with a deficit of 300 and a protein intake of 12 grams with deficit of 4 grams. Family history is a single child, no siblings, no history of congenital heart disease in the family. Child is immunized up to age according to national immunization schedule and no history of optional vaccines. No history
mention about consanguinity.
Third degree consanguinity. No history of contact with pulmonary tuberculosis. Coming to the examination.
Summarize the history.
Sir, this is a 2-year, 9 months old male child born to third degree consanguineous marriage with complaints of growth failure, recurrent respiratory tract infections, and breathlessness on exertion. Probably with no history of any cyanosis. Otherwise antenatal, natal history uneventful, sir.
So what do you think in terms of?
Probably acyanotic heart disease with increased pulmonary blood flow.
With?
Congestive cardiac failure.
When do you call it a recurrent respiratory tract infection?
More than 3 episodes per year requiring IV antibiotics or hospitalization, sir.
Is it 3? Anyone else?
6.
Any other definition?
6 months period, more than 2.
3. Okay.
Coming to the examination.
And grading of NYHA?
Sir, grade 1, symptoms present with extraordinary activity. Grade 2 with ordinary activity. Grade 3 less than ordinary activity. And grade 4 is symptoms at rest.
Anyone want to modify this? Your classification is Borg. This is not NYHA.
Breathlessness on egg.
What are the parameters you grade by NYHA?
Breathlessness, chest pain, uh, angina,
That is chest pain.
chest, sim,
Palpitation
palpitations,
and fatigue.
fatigue.
So what is grade 1?
No symptoms.
So no symptoms in,
No symptoms with ordinary activities.
yeah, patient will be having a cardiac illness, maybe anything, right from your valvular or structural, other structural, or even hypertension, without symptoms on ordinary activity. Grade 2?
Grade 2 has symptoms with ordinary activities, sir. Like going to school.
So we don't bring in a term like extraordinary activity or more than normal activity. The grading is just for a ordinary activity. So of course grade 3 is less than normal, grade 4 is at
symptoms
rest.
at rest.
Okay. So what is the grade like?
Grade 2.
Grade 2 at the onset and even now?
Progressive, sir.
So from what stage it progressed to which stage?
So from grade 2 to grade 3.
So now patient is in class 3 symptoms.
Yes.
Okay.
Examination, on general examination.
No, summarize the history and tell me your interpretation. Final interpretation.
Acyanotic heart disease.
Acquired
Congenital heart disease with increased pulmonary blood flow, with symptoms of congestive cardiac failure, with no evidence of any infective endocarditis, with no features of any pulmonary hypertension.
Okay. Okay, carry on.
On examination, the child is tachypneic at rest.
So your grading of NYHA is not class 3 now.
Class 4, tachypneic at rest.
So
Based on history.
So you correlate everything, and just before presentation, initially you said just grade 2, then you changed to grade 3. Now the general examination is at
Grade
rest
4.
symptomatic. So you correlate everything, general examination, your findings, everything. Huh?
The child is tachypneic at rest, conscious and oriented. There is no pallor, icterus, no cyanosis or clubbing, and no pedal edema. Head to foot is normal. There is no facial dysmorphism. Anthropometry, the child's weight is 9.1 kg. According to WHO standard growth charts, falls under less than 3rd percentile. Height of 85 cm, less than 3rd percentile, and weight for height also less than 3rd percentile. Vitals, child temperature is afebrile, has tachycardia of 136 per minute. The pulse is regular in rhythm with large volume and bounding in nature, equally felt in all peripheral pulses, no specific character and no radio-radial delay or radiofemoral delay. Respiratory rate, the child is tachypneic around 54 per minute, abdominothoracic type of respiration. Blood pressure, there is a wide pulse pressure and upper limb around 86/52 and lower limb around 160, and saturation is normal in all 4 limbs. JVP is not elevated.
How did you take the BP? Why do you call it wide pulse pressure?
100 diastolic pulse pressure is more than 20.
No, less than 20 is less than normal. 20 would be normal. So 40 is normal volume.
More than 20 is
No. When do you feel a pulse? What should be the pulse difference between the systole and diastole? Anything less than 10 won't be palpable. So here it's just gradient is 34 in the right upper limb and 30, it's hardly 34 to 40.
34.
So it's not a high large volume pulse here. So you recheck your BP. And how did you take the BP in the upper limb? How did you take in the lower
Sitting
limb?
position upper limb and supine position.
So where did you, what kind of cuff you used?
For a 2-year-old child, it should cover at least 2/3 of the length of the arm and 80% of circumference, sir. 5 centimeter
So what
cuff.
is the normal, what is the target width of the cuff and the length of the cuff in relation to the arm circumference?
Less than 1 year.
No, some percentage of arm circumference.
80%, sir.
That is what?
Width of the.
No, length
Length
of the
of
cuff.
the cuff.
Length of the cuff should be 80% of the
80%
arm circumference. What is the width of the cuff?
2/3
No, it's not 2/3.
in centimeters.
I don't
5
want in centimeters. Ratio between the arm circumference and your width. Ratio between the arm circumference and the length of the cuff.
Two.
So length should be 80% of the circumference. And the width should be 40% of the arm circumference. So probably you recheck with your cuff dimensions.
Okay, sir. On examination of the cardiovascular system, on inspection, trachea appears midline, chest wall is symmetrical, there is no precordial bulge, hyperdynamic precordium is present, apical impulse is visible on the left 6th intercostal space, lateral to the midclavicular line, there is no parasternal heave, no scars, no sinuses or no, epigastric pulsations. On palpation, tracheal position is confirmed, apical impulse is shifted to left 6th intercostal space, half inch lateral to the midclavicular line, hyperdynamic in nature. There is a systolic thrill present at left 2nd intercostal space along the upper sternal border and the apex. And no palpable P2 or parasternal heave, carotids normally filled, no thrill. On percussion, left heart border corresponds to the apex and right heart border corresponds to the right sternal margin. Auscultation, as the findings are more in the pulmonary area, I would like to proceed from the pulmonary area. There is a high pitch continuous machinery murmur heard of grade 4 to 6 in the left upper sternal border radiating to the left clavicle. Mitral area S1, S2 is heard and tricuspid aortic area is heard normally. Other systems.
Can you specify in relation to the intercostal space?
Left 2nd intercostal space.
Okay.
Murmur is also heard in the left clavicle.
Carry on.
Other systems, respiratory system, bilateral air entry equal, normal vesicular breath sounds heard, no other added sounds. Abdomen soft, liver and spleen is not palpable, and CNS no focal neurological deficit, clinically normal.
So more than the palpability of liver and spleen, you go for the situs. You are discussing about a congenital heart disease. So this may be associated with the malpositions, situs inversus. So you say liver dullness is on the right
side.
Tympanic resonance on the left
side.
So you give importance more to the
dull percussion.
sidedness. And also the liver span should be mentioned.
Okay.
It's not palpable, but still you have a liver span.
Okay.
What is the liver span?
Normal for this.
So what is the normal for this age group?
7.5.
Okay, you always measure the liver just to differentiate between a push down liver and a real hepatomegaly. This should be, the child is symptomatic, you say class 3 in CCF, unless you give massive diuretics but still child is symptomatic, you should have a liver. Hepatomegaly. Carry on.
On summary, it's a 2-year 9-month-old male child born to 3rd-degree consanguineous marriage with a history of recurrent respiratory tract infection, congestive cardiac failure.
From which age?
Since 45 days of life, sir.
So does it pinpoint to some diagnosis? Group of illness?
Left to right, mostly when the pulmonary vascular resistance falls, the patient becomes symptomatic. PDA, VST.
So all the large left to right shunts are symptomatic at 6 to 8 weeks of life. When do you have a fall in pulmonary vascular resistance?
Around 6 weeks.
That's in a normal child. Normal term child. Is there a difference between a term child having a fall in pulmonary vascular resistance and a child with left to right shunt and a preterm child?
Preterm child usually later life, sir.
Okay. What about term?
Term closes at falls between 6 to 8.
6 to 8. When you have a shunt lesion, the fall is even slower. So it's going to take 2 or 4 weeks later than your routine 6 to 8 weeks. So when you have a large VST, when you have a large PDA, the shunt is going to prevent the fall in pulmonary vascular resistance. Okay.
And then on examination, child had tachycardia and tachypnea at rest with bounding peripheral pulses. Pulse pressure is normal and hyperdynamic precordium is...
Pulse pressure is wide.
Wide.
Okay. But it's not correlating with your BP measurements.
Apex shifted down and out, and systolic thrill is present with continuous murmur at left.
Why do you put it as LVH?
Sir, apex is shifted down and lateral.
So what are the difference between an apex of a LVH and an apex of the RVH?
RVH apex, if it is a volume overload, the apex will be shifted down and out, sir. RVH type of apex usually in the right side, right sternal.
So which is diffuse, which is localized?
LVH is usually, if it is hyperdynamic, it is diffuse.
So any other person who can differentiate between LVH and RVH apex clinically? Yeah. Some findings are the precordial bulge is there. So that is
that hyperdynamic. He is focusing so well. Yeah.
You will be able to focus the camera on it. No sir. கொஞ்சம் படுக்க வைக்க முடியுமா அம்மா? படுக்க வச்சுக்க முடியுமா இல்லை உட்காந்துட்டு மடியில் வச்சுக்கிறீங்களா? இல்லை நீங்கள் உட்காந்துட்டு மடியில் வச்சுக்கோங்க. கேமரா எங்கே இருக்கு? இப்படி இந்த பக்கம் தலையை வச்சுக்கோங்க. நீங்கள் மடியில் வச்சுக்கிறீங்களா? அப்படியே கொஞ்சம் பேசி படுக்க வச்சுக்கோங்க. யா டெல் மீ. கொஞ்சம் படுக்க வைங்க. அடம் பண்ணுறானா? அப்படி வச்சுக்கோங்க. Child is symptomatic. No, don't get tense. Just keep talking. Just keep talking. That fellow is also looking.
Child looks
Yeah, tell me.
Child looks comfortable at rest.
So what all you was told by you during presentation which not there or which is there?
Precordial bulge.
How do you see the precordial bulge?
From the foot end of the patient
you
part,
don't see
we
it
have to
in the sitting posture. You make him lie down and look from the foot end or the head end. Okay. There is a precordial bulge anyway. Then he's not in this. Does he have some subcostal intercostal restriction?
Yes, sir.
Is he tachypnic?
Tachypnea is there. Intercostal retractions is seen, sir. And child is tachypnic.
Yeah. Okay. Why don't you just demonstrate the apex? When you are asked to tell me the apex, just What are the steps you take? Don't get tensed up, it's going to be a learning for everyone. Huh? Okay, make him comfortable and just look at the apex. Which hand you use? So how do you go in for apex? You
It
want
is
this?
a definite cardiac.
I will have that. You have this. It's 19 more minutes. So define an apex. So don't go by the definition, you just demonstrate the apex now. Step 1. Now you use both hands. You just see if it's a dextrocardia, you are going to miss a dextrocardia when you are not going to pick up the apex on the right.
Right, sir.
So first go by both hands.
Okay, sir.
So not the right hand, not the left hand. Both hands should be used. Then go in for apex. Then go for a step by step apical description.
Okay.
So is it felt in the right? No, it's obviously not felt in the right.
Sir.
So the first step is you don't miss a dextrocardia. So use your both hands.
To feel.
Then localize the apex to
With
the
one
side, and then go on to describe. So what is the apical impulse? What is the definition?
It is the lowermost and outermost definitive cardiac impulse which is felt.
Which is giving a perpendicular lift to your palpating
finger.
Yeah. Do that. Okay, child is not, will carry on, sir. Sir, will carry on. Child is not cooperating also. Scabies. உடம்ப அரிச்சிக்கிறானாம்மா பிச்சுக்கிறானா Okay, carry on. So how do you differentiate a LV from a RV?
LV apex to
LV is more of a localized impulse, RV is more of a diffuse. Any other difference? As you said, outer and getting displaced downwards is LV. Only just outward is same space laterally is going to be RV.
apex.
Other thing you see for parasternal heave. The apical impulse is continuous with the parasternal heave, it's RV. If there is a zone of medial retraction, it's the LV. And LV is usually associated with the epigastric pulsation. Whereas RV is usually associated with the epigastric pulsation. LV need not be associated unless it's when the RV is involved. So these are 4-5 differences. Okay, carry on. Why did you go to differential diagnosis?
Apex shifted down and out, and a systolic thrill and a continuous murmur is felt at the left upper sternal border, the second intercostal space, radiating to the infraclavicular area. There are no signs of pulmonary hypertension.
So this is what you missed. Infraclavicular, you didn't describe it properly in the when you are describing about the murmur. Just go through to the murmur. Auscultatory finding. Auscultate. Just tell me the findings.
High pitched continuous.
Always go to the sounds S1, S2. Then go for additional sounds like S3, S4 or a clicks. Then go in for a murmur. Don't go straight away, jump to the murmur. Always start talking about, give importance to S2. When you say no pulmonary hypertension, P2 has to be told
because
in
of the
detail.
murmur, S2's Not heard.
Just don't say it as murmur first. You start as sounds, then additional sounds, then murmurs. Okay. So why don't you just re-describe the auscultatory finding?
Pulmonary area, S1 is heard, S2 not well appreciated, so because of the high continuous murmur. No loud S2 and no clicks heard. It was a murmur, high pitched continuous machinery murmur of grade 4/6 heard over the left second intercostal space, radiating to the left infraclavicular area.
Any other theoretical sake, any other sounds you can expect or you say when you give this diagnosis? Which is specific for your you gave a differential diagnosis and you give PDA as a diagnosis. Any specific sound you have?
Venous hum.
What are AD sounds? Just go read about it. Okay.
A diagnosis. It is a acyanotic congenital heart disease with increased.
No, diagnosis, before diagnosis you summarize the history, then your clinical features and then come to your diagnosis.
Summary, 2-year-old 9 months male child with history of recurrent respiratory tract infections, congestive cardiac failure, failure to thrive with no cyanosis, and on examination as tachycardia and tachypnea at rest, bounding peripheral pulses, wide pulse pressure, and hyperdynamic precordium with shifted apical impulse, hyperdynamic in nature, and a systolic thrill, continuous murmur at left upper sternal border in the second intercostal space, radiating to the infraclavicular area, and with no signs of pulmonary hypertension or infective endocarditis.
Okay.
Diagnosis, it is a acyanotic congenital heart disease with increased pulmonary blood flow, probably moderate to large PDA because of features of growth failure.
When do you say small PDA, when do you say moderate, when do you say large?
Usually small PDA or asymptomatic, sir. Moderate PDA, there will be features of congestive cardiac failure and growth failure and cardiomegaly. A large PDA with same features but S3 apex.
S3 can occur with any moderate or large.
Flow murmur, mid diastolic murmur at the mitral.
Flow murmur MDM is always seen in moderate PDA also.
Enlarged pulmonary artery.
It indicates a large left to right.
Features of pulmonary hypertension.
Features of pulmonary hypertension. Mild can occur with moderate PDA, but a moderate to severe PH favors a large PDA. Okay.
With the congestive cardiac failure in sinus rhythm with no evidence of pulmonary artery hypertension or infective endocarditis with growth failures.
So this pulmonary hypertension component you need to verify. Okay. Okay. You have a severely undernourished child who has been symptomatic from 45th day of life. So probably it's a large left to right shunt. You will have pulmonary hypertension.
Differential diagnosis, sir. A venous hum is a common differential diagnosis, usually seen in children and high output states like anemia, thyrotoxicosis. Usually heard in the right supraclavicular, infraclavicular area and sitting position.
Before going to that, you made a diagnosis of PDA. What is specific for PDA in this clinical
continuous
features?
murmur.
Continuous murmur, you are giving a DD. What is specific in that continuous murmur for a PDA?
Heard in the left upper sternal border and the infraclavicular area, sir.
Yeah, sight is one.
Right.
Any other thing?
S2 is not that much appreciable.
So what does it mean?
The continuous murmur is a form of crescendo decrescendo murmur.
It can be like a crescendo, so the peak may be in the mid systolic and slowly it may be a decrescendo which is going on to the diastole. What is specific for a PDA?
Because of the pressure, aortic pressure is high, there is
no peaks at S2.
S2.
So other all these DDs don't peak at S2. It may peak in the some other part of the systole or some other part of the diastole. So it peaks in this at S2. That is specific for PDA. And theoretically, eddy sounds are very specific for PDA. Then go on.
In arteriovenous fistula, like coronary and pulmonary systemic, aortopulmonary window is same like
But
PDA.
just tell me 1 or 2 points in each. Venous
Venous common in children with anemia, thyrotoxicosis.
No, specific for venous
Sitting position, it is better posture.
Okay. Usually anemic child may
Anemic
be
child.
associated, more common with anemic children. Okay. Then
Then coronary pulmonary fistula will be cyanosis. Systemic usually heard in the site of head, liver.
so coronary, the site is important. It's more in the
Right.
pulmonary area,
Yeah,
lower
lower
left sternum
sternum
border,
border.
or in the apical. Pulmonary, of course, in the peripheries, not in the cardiac region. It's going to be in the peripheral fields.
Cyanosis.
Yeah, systemic, of course, when you have the systemic in the hand, you are going to, systemic AV fistula in the hand, you are going to have the murmur there. Okay,
then
site is very important.
Aortopulmonary window mostly systolic murmur mimicking VST, sir.
It's
always,
almost always a
is
systolic murmur.
murmur.
Even though we bring it under differential diagnosis of PDA, it's 80 to 90% it's going to be a systolic murmur. Why?
Because the pressure gradient is almost equal, so
It
only in
equals
systole,
with diastole.
no diastolic
There is no
leak.
flow during. There is no turbulent flow during diastole. Okay.
Then collaterals in TOF, the TOF child usually be cyanosis will be present, cyanotic spells, squatting episodes.
So that is from history. Site of murmur.
Site of murmur lower left sternum,
Axilla back.
back radiating to collaterals. Aberrant origin of left coronary artery and VST with
Those
AR.
are rare. We don't.
VST with AR to and fro murmurs. Repeat of Blalock.
Okay, we'll leave it. Okay. When do you have a PDA and you don't have a murmur?
Silent PDA.
What is silent PDA?
With not audible murmurs, only in echocardiography times.
It's picked up only by echo, not by your clinical examination. The sounds are normal, meaning S1, S2 is normal. There is no murmur. So what is the treatment difference between a silent PDA and a small PDA? Why do you classify some PDAs as small PDAs, which are silent PDAs, and small PDAs? Is there
Small
a reason?
PDAs has to be closed, sir,
Yeah.
even though
Silent need not be
Be
closed,
closed.
because the incidence of, why do we close a PDA, small PDA?
because feature pulmonary hypertension eventually develops and goes for Eisenmenger
Do
syndrome.
we have a pulmonary hypertension in a small PDA?
No, sir. A recurrent infect. No, sir.
Small PDA is totally asymptomatic. It is not going to cause CCF. It's not going to cause infected endocarditis. Still, why do we close a small PDA?
Later, size may increase.
It doesn't grow. So, risk of infective end arteritis. It is not endocarditis because the vegetation is in the artery. So, it's going to be a end arteritis. The risk of end arteritis is more than the risk of the procedure, whether it's going to be a device closure or going to be a surgical closure. So, you close a PDA for the risk of end arteritis, not for CCF, not for
pulmonary hypertension.
Okay. You have a PDA but it's not audible. What are the other DDs?
In features of pulmonary hypertension develop
severe PH, Eisenmenger, PDA becomes silent. Why?
Because the pressure reverses diastolic
because
component.
there is no turbulent flow across the defect. Okay. Any other reason for a PDA becoming silent? One is a preterm child. With age,
Initially
it's going to
systolic
close, or you are going to close it with medical closure. Any other reason? Long tortuous PDAs, PDAs with valves. These may be silent also. Or a PDA, rarely you develop a infective endocarditis. I mean infected endarteritis, that vegetation is closing the duct, or a thrombus is closing the duct. These are very rare causes for
Silent.
PDA not being
Audible.
manifesting. Okay.
Then general discussions.
Okay, we'll go to the management part. Yes.
Examiner asks what are the differential diagnosis, being a continuous murmur, then what you have given as differential diagnosis is all right. But after presenting all the case history, everything, recurrent respiratory infection, you should limit differential diagnosis only where is the question of repair TOF. So you understand. So this is not the differential diagnosis after you presented all the cases and this you must have this, and then child is saying his scabies all over, he is scratching, his papro, you must not miss some skin conditions. Okay, so I wanted to make these points because he is giving, if you ask what are the differential, continuous murmur, then she has to enlist all the causes. But after presenting the whole case and then you have seen, then you should limit only 2 or 3 differential diagnoses like aortopulmonary window, etc. This required TOF, all these things will not come at all. Okay, just so that you don't make this mistake and again. Then in your interest only I am telling, please understand. No, not criticizing, don't get disheartened. Okay.
So what do you do with this PDA?
First investigations, investigation.
We are just having 3 minutes. Yeah, tell me.
Investigations, I would like to take chest X-ray, then ECG to look for left ventricular hypertrophy and echocardiography to diagnose.
So what do you look for in the ECG? What do you look for in the X-ray?
X-ray, there will be cardiomegaly, increased pulmonary vascular markings, enlarged aortic knuckle, enlarged pulmonary main pulmonary artery, and Manchester.
You said cardiomegaly. Which chambers are enlarged?
Left ventricles.
What about left atrium?
Left atrium and left ventricle will be enlarged.
Okay, you have the X-ray
pulmonary
with you. You have the X-ray with you. Yeah, and just trace the borders.
So from here, there will be left atrium, aortic knuckle.
Which is left
prominent
atrium?
aortic.
No.
Finish. This is left atrium, aortic knuckle. Aortic knuckles prominent.
No.
Left atrial enlargement.
Just see the arrow where you are pointing. So that is what? Lowermost.
This is left ventricle.
Okay.
Sir. Apex and left ventricle.
How is the LV apex or how is the RV apex?
RV apex is not enlarged.
So talk about cardiophrenic angle in a LV and RV. It looks like a RV apex, no? It's not dipping into the diaphragm. It's more of angle is acute. So typical LV apex will be dipping into the diaphragm and the angle between the border and the diaphragm will be obtuse. So what you say is LV, then the LA,
so this is not
then
the
PA
X-ray,
and the aortic
this is not
knuckle.
the X-ray of this child. This is a female adolescent girl. You can
So
see the
this is
breast
not
shadow.
that's what it's not fitting into your PDA diagnosis. Just mark out the border of the right side. This is not the patient's X-ray. Name is not also not there. Okay. So theoretically, right border. Just tell me the right border.
Right. So this is SVC. SVC. Sir.
SVC. The lower one is
pulmonary artery.
no.
Main
Pulmonary artery doesn't come there. The lower half is the right atrium. The upper half is the SVC. Okay. So RV. Where is RV seen here? It's not seen in the borders. Okay. Tell me the ECG.
ECG usually in the left side chest.
It's also not the
leads,
patient's ECG. You try to get the patient.
There,
so yeah.
Okay,
You always get the patient. This is also doesn't show a LV diastolic overload. No, this is not. So what do you look for a ECG of a PDA?
Left side, thal.
What is the axis in a PDA?
There will be left ventricle, I put non.
What is the axis in a PDA? So it has to be normal
Normal
or
axis.
right axis deviation. When you have a left axis deviation, any DD,
Right when palmar.
you think in terms of rubella. So other features of ECG evidence of PDA. Axis,
LVH.
you get to your etiology, rubella. Then what
Tall R waves in left side chest leads.
So you have a RAE and a
it is changes
LV,
in
volume
MV1
overload
V2
pattern. Okay. So we are not supposed to continue after this. It's time over. Okay, just tell me the treatment of PDA. In general, about treatment.
Sorry, if it is a preterm PDA, medical closure has to be done with indomethacin, 3 doses, 0.2 milligram per kg per dose, or ibuprofen can be done.
Ibuprofen in how many days?
3 doses, 10 milligram, followed by 5 and 5, 24 hours apart.
10 mg. Is this thing, indomethacin?
Ibuprofen, sir.
Indomethacin regimen?
0.2 milligram per kg per dose, followed by 0.1 milligram per kg per dose, 12 hours apart, totally 3 doses.
Okay, ibuprofen?
Ibuprofen 10 milligram per kg per dose, followed by 5 milligram per kg, 24 hours apart, 24 hours apart, 3 doses.
Any other drug?
Paracetamol.
Paracetamol has been given. It's found to be effective.
Then if it in larger infants, usually term PDA will preterm PDA closes by 3 months.
No, we'll leave about medical therapy, interventional or surgical therapy. When do you close a PDA?
If it is symptomatic, sir, with congestive cardiac failure, failure to thrive, increased recurrent respiratory tract infections.
So small PDAs, when do you close? It's no CCF, no pulmonary hypertension, no recurrent.
1 year.
1 to 2 years. Moderate?
Moderate after correction of CCF.
6 months to 1 year. Large? 4 to 6 months of age. So how do you close a PDA?
Using small coils or multiple
when do you use a
coils.
coil? When do you use a device?
If it is less than 3 millimeter, we can use.
So very small PDAs, less than 3 millimeters, you go in for a coil.
Larger PDA, device closure. Device closure.
Okay, you have some videos on device closure. So nowadays almost all PDAs are closed by devices or coils. So this is the PDA demonstration in the lateral view. You see this. You have a pointer. So you just run the PDA. This is a pigtail catheter in the arch of the aorta, and this is a small PDA opacifying the pulmonary artery also. This we are taking the catheter from the femoral vein to via the IVC. We are entering the RA, RV, and from the pulmonary artery we are entering the PDA, and this is the descending aorta. This slides was meant to just show you that device closure is the predominantly used method to close a PDA nowadays. Almost no case goes to a surgeon now. So we are sending in a sheet through the wire and placing it at the level of descending aorta. Can you just go on to the, because time we are not, shortage is there. So this is the device, it's loaded onto the sheet. We are trying to release the device into the arch of aorta, that is just at the aortic end of the PDA, pulling it into the PDA and then releasing the device from the wire. So this is the PDA This is the aortic end. This is into the PDA. This next. So this is the PDA in situ. So any other specific questions needs to be answered? This is the check angio just to show you that there is no shunt across the duct. This is the check angio where the dye is injected into the ascending aorta, I mean the arch of aorta, and this shows the device in position. There is no shunt across the device.